Population Services Kenya is a leading non-governmental organization with over 25 years collective experience of supporting the Ministry of Health in addressing priorities in TB, HIV, malaria, reproductive health, and also in non-communicable diseases. Specifically under tuberculosis, we have implemented TB Reach, both Wave 4, Wave 8, and Wave 9 projects. And also, we are a leading organization that helps the National TB Program in communication for TB prevention and treatment and also care.
So we have been implementing this TB active case finding through the public-private mix strategy. So overall, the country has been missing about 40% of its TB cases annually, and the private sector was actually realized to be one of the points of entry of care, where TB case finding could actually be accelerated. Overall, that's what we've been supporting the country to do through the TB Reach Wave 8 project.
TB Reach Wave 8 started way back in October 2020, with beginning with startup activities and co-creation with the county TB program, whereby we had a session just to co-create and understand the gaps and the areas where the response could begin, and after which we now began the mapping of the facilities, identifying the facilities and selecting them based on their capabilities to be engaged in TB. We engage a number of categories of providers. We engage standalone laboratories, we engage chemists, we engage health facilities, of whom some of them we upgraded into treatment sites for TB. And they began to manage TB as quick as we begin to start the case finding. After which we had a session to train them on how to manage TB. We trained over 120 providers and sensitized all the pharmacies and the laboratories on TB management.
We've been doing our usual duties of selling and dispensing medicine to the population. But since the PS Kenya came and introduced us to the TB program, they took us into a TB training where we were oriented and we started working on the cases. We started screening the patients.
Our active implementation now in terms of reporting the numbers began in January 2021. Whereby we began to see numbers, patients being identified, patients being screened at the facility level, and so far we have engaged 258 private providers. This is both, so of the 258, 227 are private health facilities, 40 of them are chemists, and 8 of them are standalone laboratories. Out of the 227 health facilities, we have upgraded 23 to be treatment sites, and the providers are excited, so much excited that they're able to manage TB, and their capacity have been built.
Since we started working with TB Reach program this year, January, we've benefited a lot. The reason why I'm saying this is because the previous years we used to have a few TB clients, but since January, we've been able to enroll so many TB patients.
Majina yangu ni Patrick Maina. Naishi hapa Growon B. Yaani hiyo mwezi wa 5 pahali nilikuwa nilianguka na nikalemewa kwenda. Huyo alinunua niletwa mpaka huku. Bukio ni picha. Kupelekwa huko ni rahisi. Picha ile kurudi huku nikasemekana niko na TB. Sasa ni dawa tu. Hizi dawa naona imenisaidia. Juu sasa siyakuwa vile nilikuwa. Sasa unaona nada kama ni kulikapa. Dawa zangu la kujawa hapa. Kisa peo na mesa tu. mesa, naenda hakuna kitu nalipisao.
We also have the CHV who is supported, who helps us with the home visits, and also we have a rider who is also supported, who comes every day to collect the samples to Mathare North.
We also have an added an operational research component just to begin to understand how we can improve TB documentation in the private sector by having a mobile-based application. This mobile-based application is based on DHIS, the DHIS. So it's a DHIS app, but it's based on the mobile. In this mobile-based application, the provider uses his phone to screen the patient, and if there is a presumptive, then they refer and feed in the feedback to the app. And then if the patient is positive, then they track the patient through treatment, which is very exciting to private providers because it's trying to reduce the burden of the workload of paperwork and all that. This has really brought some uniqueness to this, and even the county team are also excited to walk along to see this happen.
Initially, before PS Kenya came in place, we were not getting referral of TB cases or suspect from these other private facilities. So far, so good. My case finding has really improved steadily, right from the time we started engaging PS Kenya.
Since we started the active implementation of these projects, we have seen the private providers screen a number of individuals. We have screened over 76,000 individuals at the facility level, of whom we have identified around 14,000 as presumptive and tested quite a number. And we have identified 248 TB cases. And all of them have been linked on treatment, apart from a few who died before being initiated on treatment.
In this program, we always screen our patients, and we take samples. We call our rider, who always comes and take the samples to the gene expert.
We've been working with the PS Kenya in terms of sample networking. Sample collection from various facilities in the sub-county. This includes the private facilities.
We have around 17 facilities which are sending samples to this lab. Once the lighter brings the sample, we normally counter-check the samples first request forms. There is a criteria we use for selecting samples. Once we have done all that, we put our samples in the saved hold. Once we have done so, and once we have labeled, once we have arranged them as per as they come here, we have a marker pen. We start now registering the request forms into our TB register book, and then from there we start giving the samples numbers. As you can see from here, so far we are now in. From the time we started, now we are sample 3,655.
After receiving the samples, we have selected, they have passed the criteria, we have given them lab numbers. Now we come to processing. In processing, we take the sample, like this one is number 3651, that is our lab number. So this sample, we shall check the volume. If the volume is 5 ml, we mix with the diluent. This is the diluent for the sample. So this diluent is 8 ml. So if the sample is 5 ml, we will mix double. The diluent will be double. So in case this is 5 ml, we shall add 10 ml of the diluent. Then we incubate in this safety hold for 20 minutes. After that, we shall transfer 2.5 ml of the incubated sample using a special pipette. Here it is. That is our pipette. It has a mark, so once you spread the sample up to past this level, that is 2.5 ml, then you dispense in the cartridge. This is the cartridge for Gene Expert, Gene Expert for TB. So you open the lid, you dispense the sample. After dispensing the sample, you take it back, you close the lid. Then the sample is ready for running in the Gene Expert module. After mixing our sample from the biosafety cabinet, we come with it, and then we want to run in the Gene Expert machine. So before we run in the Gene Expert machine, we have to come to our desktop. There is a software for Gene Expert, whereby we go to the section written create. So after clicking create, it will say scan the cartridge. It is either manually, or if you scan, we use this gadget here. So you scan, it has barcode here. This is a barcode reader. So once you scan here, it will, the cartridge number will appear on the system. Then you fill in the names and the lab number for that client. Then after that, you command start in the machine. After commanding start, the desktop shall notify which module are you going to operate from. If it says module 3, it will give light at port 3. So you'll open that, that is the module. Then take your cartridge, insert in that cartridge. Then you click on the desktop, start. After that, then you close that cartridge. Then it will run for 2 hours. After 2 hours, it shall transmit a result, whether positive, invalid, or negative, or error to the system. Then the results are ready to send to the client.
Some of the challenges that we've had are in the private sector is quite an interesting place. It is hugely amorphous. Facilities are very different in architecture and structure. Even medical centers differ. Some of them being very huge facilities that have EMRs in place. These are electronic medical records. Some of them are so far ahead in terms of being trained on how to do active case finding, so that they've inbuilt TB screening questions within their EMRs. And then others are the kind of facilities where there's no much information, there isn't much to work with. The private facilities also tend to be areas where health workers have a really high turnover, because the facilities tend to be small and the pay tends to be a bit minimal, so there isn't motivation to stay put. So you're always training, always working with facilities, always being present, always training a different provider. For you to be able to sustain the work that you do, you need to be continuously present. So this has necessitated us to work with key focal people on the ground, our foot soldiers, our TB technical assistants, who do the work daily, being present, being in contact with the private providers to make sure that the work is done. Another challenge that we've had with COVID-19 particularly, with the stigma associated with being found to be COVID-19 positive, and then either going into quarantine or isolation, and all that talk around COVID has actually made people afraid to report that they have cough symptoms. So even when they walk into a facility, they would ask for treatment, but they wouldn't directly admit to having a cough. And even if they did, then they would be really adamant to produce a sputum. So what happens is that we see very high numbers of people who are presumed to be TB cases, but then very few are giving us samples for testing. And that means then the yield we're looking at on the other side is a bit low. In addition, the Gene Expert infrastructure that exists in the country that we take advantage of has had challenges this year. There's been quite regular stockouts throughout the year of the cartridges, particularly in Nairobi County, due to the fact that Nairobi actually has the highest burden of TB. So we've been in contact all through with the TB program, as well as the county and the Nairobi County and sub-county focal people, to see how to work around the commodity and forecasting issues, but they continue to be a pain point. A lot of our results samples actually sit in the labs for a long time before they're tested, and some end up getting lost in the mix. But we have to say that we've still seen a great deal of success in the program.
The challenges we are having right now in TB testing is lack of TB commodities, that is cartridges in Gene Expert testing. However, we've been forced to go back to microscopy for testing TB.
Training were limited to virtual training, and the majority of healthcare workers were not comfortable joining virtual training, and if they did not stay in the training until the end. But with the support of PS Kenya, we've had a number of outreach services whereby we've been able to reach out to many clients. We've done a lot of screening in the community, and out of that screening we've been able to get a few cases. My wish is that we could get more support beyond December this year, so that we continue reaching out to non-engaged facility. Dagoretti, we have so many private facilities that we have not been able to engage due to limited resources. But if PS Kenya can get more support, I'm very sure we are going to reach out to all service providers, because I believe that those TB patients that are missed out in private facilities that have not been engaged by PS Kenya. Thank you.
And we are very much grateful for your support. Thank you.
Given opportunity, we are willing to be part of the TB treatment program, whereby our clients will be coming here, we'll be dispensing them the drugs together with the TB coordinators, and by doing so, they will be talking good of us outside.
Achievements ambazo tumepata kwenye jamii ama community ambayo tunaishi kwa sasa ni kwamba wale ambao tumeelimisha wameweza kuwa wa msaada kwa kutusaidia kuelimisha wengine kiwango ambacho wanajileta wenyewe hada mpaka kwa facility ili wapate kusikia zaidi kuhusu TB, na wamekuwa wa msaada, maana hii habari sasa imepata kutoka kwa mtu mmoja ikisonga kwa mwingine. Tunashukuru sana kwa kuja hapa mashinani the TB Reach.
So we look forward to technologies that ease the burdens and the barriers around testing to be more available, mobile forms of testing, x-rays and the innovative digital x-ray use that we were taught about in a webinar a few months ago. So we look forward to such moments for us to be able to do better with the Stop TB project. But so far it's been quite a learning experience, a lot to learn. One of the successes of the project, and I think one of the main sources of information for me personally, has been the quarterly review meetings that we undertake, where we sit down with a larger team. We bring on board the sub-county focal people, the county focal people, we bring on the national TB program, and then we take a deep dive into our data. We bring in our motor riders who do for us sample transportation. We also bring in our CHVs. And then we look at the data together and try to address the challenges. So out of that, once we've looked at our deep dive of our data, we come up with action points and then agree on when we'll sit back and resolve. So it's been really great, because how we have implemented the project right now has been a lot from what we've learned, and we may have deviated a bit from the original thought just to match the challenges that we find on the ground, which has been a really key point for us. So there's been a lot of potential there, a lot of learnings from there, and then definitely a lot of potential for future work in the project.